Good morning again.
So please, it's 10 o'clock. We're about to start.
We are just going to start the next session.
Everyone,
Yeah. So, thank you very much. So, welcome on the next session, or on the orthopedic session. On the beginning, let me introduce us as a chairs. Eric Domelov, developmental psychologist and scientist from Sweden, and me, pediatric orthopedic surgeon from Poznań in Poland. But the most important person here is Professor Muharrem Yazici. It's a great pleasure and privilege to me to present and invite him on the stage. He is my friend from many years. He is a pediatric orthopedic surgeon from Ankara, Turkey. He was trained and worked in Turkey, of course, and in United States. He chaired both European Pediatric Orthopedic Society and Scoliosis Research Society in the past. More than 80% of his clinical practice consists of musculoskeletal problems seen in patients with neurodevelopmental conditions. In his research, he focused on early onset spine deformities and also neuromuscular spine problems, which appeared in all ages for many, many years. He is an author of many articles and books addressed for the orthopedic surgeons, but not only, but also for all who are dealing with the posture and stability. Besides spine, lower extremity, mobility, and childhood motor disability were also his fields of the interest. We have the chance now to ask him to share his experience with the management of spine deformities in patients with low-tone neuromuscular disease. Muharrem.
Good morning. My name is Muharrem Yazici, as Marek said. First of all, I'm so honored and privileged to be here today. I'm a pediatric orthopedic surgeon, is mainly focusing on the pediatric spine deformities. I would like to share my clinical experience, of course, under the lights of current literature with you in the next half an hour. But before starting my speeches, I would like to thank Marek and Katya inviting me and having me in this meeting. It's a really great honor for me. I just little bit modified my title today is Management of Spine Deformities in Patients with Neuromuscular Diseases, but mainly focus on the low-tone neuromuscular conditions because in the recent years, lots of things change in this field particularly. Nothing to disclose. First, maybe it's a great idea to start the definition of neuromuscular deformity. As you know, it's the very wide category, and we are just collecting the apples and oranges in the same baskets. And because this spinal muscular dystrophy and spina bifida, or Rett syndrome and cerebral palsy, all these are completely different entities. But because of rarity of the disease and because we don't have sufficient data for each specific pathologies, because of some of common features, all these pathologies, we are collecting all together. We are trying to find some answers for our questions because they share some same symptomatology, and at least in the low-tone neuromuscular conditions, life expectancy is a big problem for our decision-making process, and also they have limited activity of daily living. My mission today to find the answer for these very tricky questions. spine deformity surgery in severe neuromuscular disease truly beneficial? Because all around the world, we are continuously discussing this issue, and honestly, we don't have a clear answer yet, but hopefully my speech will help you to find some answer for your questions in your minds. As I said before, neuromuscular conditions is a variety of symptomatology, a variety of conditions. If you have a patients like these three, I mean, the patients have some neurologic problems, some neurologic disability, but in daily life, they can sit, they can walk, they can communicate to others, and has deformity. But the deformity looks like very similar as we've seen in the idiopathic patients, otherwise healthy population. I mean, low tone, this is the low lumbar spina bifida, CP-like disease in autism, and the CP, but it's a very high level of function. I think there is no discussion about that. And all we are agree in this room, they need some surgical intervention. We should do as we do for other healthy children. And also, some of the neurologic conditions, like congenital muscular dystrophy patients from my old days, came to me with a significant deformity when she was 6.5. I mean, she had some significant problem, especially in the upper extremity, but she's still able to walk and stand and participate daily activities. But he developed significant spine deformity we call early onset scoliosis. We manage his deformity as we do for other young child. But this is $1 million question here. Duchenne muscular dystrophy is a 14-year, fully wheelchair dependent, and significant upper extremity weakness. And unfortunately, his life expectancy is not longer than in 1 or 2 decades. GMFCS 5 cerebral palsy patients, lots of comorbidities, trach and GI tube and many other problems, or high lumbar or low thoracic myelomeningocele, complete paraplegia, incontinent, lots of pressure sources over the ischium, and there is no normal and good life expecting him, or spinal muscular atrophy type 2, but she already developed very bad deformity when she was 3.5. What we can do, what we should do for this group of patients, either low capacity for activity, a low chance to be active in normal life, or very short life expectancy. We have lots of controversies. Unfortunately, our controversies are not limited only medical field. Medical field, maybe we can find the answer easily. We can solve our problems easier than the others. We have ethical dilemma, ethical controversies, because our solutions for their problems, it's big, it's complicated, it's expensive. Should we take kind of sources from the public to give them? Do we have a right to do this? And also, we are doing such a great things in their body without their permission. Do we have such a right to do for them? This is ethical and economical. As a surgeon, as a doctor, I'm a little bit embarrassed to speak about the health economics, because it seems to me it's not humanistic. But if you are dealing with the country's economy, and if you are in the health economics, you have to consider all of these things. Giving the money to whom? And the money is given to them is coming back to community. This is very difficult question to answer, but there still exists somewhere. Again, coming back to my previous question, during my all speeches, I'm just repeating this question because I believe it's very important. This is the GMFCS5 CP, congenital muscular dystrophy, is in a very cachectic and very low condition patients, and again, another GMFCS5 patients. The spine surgery is truly beneficial for them. Why we are asking this question to us? Because we are, in our spine clinics, we are doing lots of spine surgery from easy one to tough one, and they're less risky to high complicated. Why we are asking this question for this group of patients? First of all, maybe to say something about the differences between idiopathic and neuromuscular, gives us some clue. The neuromuscular spine deformities in general, are different than the idiopathic ones because of age of appearance, risk for progression, natural history, efficacy of conservative treatment, and necessity of surgical intervention. Just summarize all of these things. They appear early in their age. They always progress. Conservative treatment, unfortunately, doesn't work well, and majority of them, from the spine surgeon's perspective, needs spine surgery. And also, deformity characteristics are different than the idiopathic one. In the idiopathic scoliosis, the spine deformity mainly affects the thoracolumbar area, just limited the spine, and mostly stabilize at the maturity. In neuromuscular side, pelvis is part of deformity, and as they don't have any compensation mechanisms, the spine is collapsed, and also deformity progress after the maturity. Neuromuscular patients, lots of comorbidities, extra problems to make our job difficult. There's spine is osteoporotic, pelvis is small, hips is mostly affected from the underlying disease, either contracted or dislocated. They have lots of systemic problems, and the pulmonary, cardiac, GI problems, and also because of osteoporosis, they already have even fragility fractures or they have high potential for in the future. And especially not low tone, but the CP patients, seizures and mental retardation and spasticity also is a big threat for the spine surgery practice, because after the surgery, and as you don't have really strong fixation because of osteoporosis, because of bony formation, insufficient bony development, the seizure or mental retardation, all these things, it puts the big risk for your implants. And also infection rate is significantly high, all neuromuscular because of nutritional problem. Another interesting point, the spine deformity is most striking, remarkable problems for those patients, but is not a sole problem of patients, just tip of iceberg. We see the spine is crooked, but this spine, this crooked spine, is very significantly handicapped, lots of comorbidity patients' spine. We shouldn't forget. We can correct deformity. I'll show some case examples in all three planes, but unfortunately, we cannot cure or heal the disease. And it means the pathology or disease, it plays own game. Even you did lots of things. To summarize all these things, the surgery is indicated for the progressive curves and causing functional losses. Functional loss shouldn't be considered only walking, inability to walk. The walking is function, but standing is function. Sitting is function, sometimes is the most important function of the patients, even breathing, feeding, and hygiene. All they are as a function, and we should consider all this function when we are making a decision for spine surgery. If we have a successful spine surgery, we can get balanced sitting, independent use of upper limbs, effective respiration and pulmonary clearance, good nutrition, easy management of GI reflux, and better nursing care. But this is not cheap ticket to go somewhere. This is very difficult. This is a very big disadvantages. Major surgeries, meaning expensive and complicated, and it needs major hospital by experienced surgeons. In the past, we were saying this code significantly. With successful spine surgery, maybe we may not add years to the lives of patients, but we can add life to their years. I put the question marks at the end because I'll tell something more at the end of my presentation. And the early intervention, we can reduce, maybe cannot eliminate completely, but we can reduce all these disadvantages as much as we can. Surgical treatment is complicated, demanding, and expensive, but also we can get remarkable results from surgery, but functional improvement or functional recovery is limited due to nature of the disease. We shouldn't forget this. The main goal overall, I'm not going deep in dive to technical details because this is the non-surgeon audience, but I'll show some picture and the clinical radiological images. Our main intention to make the pelvis parallel to ground, to bring the head to the center. Most importantly, this is something new. In the past, we were only looking in the AP view, but now we are looking more and more in the sagittal view, more concentrate on the sagittal plane because we know the sagittal plane restoration is more important than most of the time from coronal plane. As a surgeon, we are looking to perform three-dimensional correction of deformity. Our implant should be strong enough to eliminate need for external support, should be a low profile as much as because they have very low, very thin skin coverage. And if it is needed, the instrumentation should be extended from upper thoracic to pelvis. What kind of complications we are fearing? We fear from pulmonary complications. I think it's the most important one. Extended ICU stay and intubation, it's a problem. Sometimes we have some difficulty to wean the patients from vent and need some tracheostomy, and even the patients after the surgery being vent dependent. Coagulopathy is also a really important problem. We have to have all the precautions before surgery. Neurologic deficit, luckily it's not so high at these days because of help of neuromonitorization, but still the problem, an infection. I think if you ask me which one is in the top of your list, probably I'll put the infections in the top because this is very important. Okay, going back again, the same question. Sorry, maybe it's boring for you, but this is very important. To answer this question, it's not enough to look the X-ray. Wow, such a great surgery. What a great surgeon. Well, it's meaningless. We have to look the HRQL and the patient quality of life. Because this questionnaire gives us more information than our X-ray results most of the time. But unfortunately, we don't have too many well-established, well-planned, well-executed HRQL studies. Many of them has a weak methodology, And besides CP and also CP questionnaire, it's not really spine-specific. No disease-specific instruments we have yet. And the mental retardation, because of mental retardation and the communication problems, mostly we are getting the information from patient and the caregiver. And they have some bias, they have some subjectivity, it's not reflecting on the real patient's feeling or experience. And also, we can compare the pre and post-op period. We can get some results, we can make some comments on it, but as the underlying disorders is being progressing, our immediate post-op results will change in time, not related to the spine deformity because of neurologic conditions. This is also makes difficult to interpret our questionnaire. Anyhow, we still have some. We are thankful. This is probably the first in the literature, and this was very discouraging. But if you look now from the almost 30 years back, this paper is a big flow because very few number of the patients, only 37, and very short follow-up, and they reported no clinical significance between surgically and treated and untreated patients. This was very discouraging for surgeons. But the surgery in that years were not the same as we are doing today. Intensive care facilities, anesthesiology conditions are not the same as the 30 years ago. Today, I must say, I'm so happy to share all these papers with you. We have really good evidence in our hands, really good support from the literature. For example, about the cerebral palsy, after the surgery, even GMFCS 5 CP patients, significant improvement in the pain, happiness, and frequency of feeling sick domains. And also, parent satisfactions is always better than the caregiver satisfactions. It's something interesting because parents mostly looking at aesthetics, cosmetics. Caregivers are more focusing on functionality. But even though both the satisfaction is really high, and they didn't found significant correlation between satisfaction and radiological improvement. But if the patient have a worst condition preoperatively, it's very interesting findings also, their improvement is more striking than the other relatively good patients. About the other neurologic disorders in the rats, yes, they can get better seating position, better breathing, fewer episodes of pneumonia. This is very important. How about the Duchenne and SMA? Even the neurologic conditions, neurologic capacity is progressively deteriorating the course of the disease. They still reported significant improvement, quality of life and function and self-image. Relatively very new paper about the Duchenne muscular dystrophy. This is very important. Both these two low tone groups benefited from surgery in terms of bodily pain and social functional scales. How about the risk-benefit ratio? Let's look on the cerebral palsy again first, because we have a lot of information about the CP. Now, the significant improvement in HRQL maintained 5 years. The previous papers has a short follow-up. This is one of the longer follow-up. We get some good results. We can keep these good results as is, even more than 5 years. And the complication rate is very interestingly, doesn't correlate with the HRQL's changes. This is a very interesting study. It's published in 2018 from a very close friend of mine from Johns Hopkins. they reviewed 160 patients with GMFCS5 cerebral palsy. And for parents and caregivers, spine surgery is ranked #2 after the GI tube insertion to improve the patient's quality of life. This is very, very important and encouraging results to all of us. There's another important paper just recently, not recently, but 4 or 5 years ago, published in the JPO again. We know in the Duchenne muscular dystrophy, pulmonary function is declining over the years because of the natural history. Its overall 8% FVC decline is being reported. If you left untreated, if you are not doing anything for spine deformity, FVC of the Duchenne muscular dystrophy patients is declining 80%. But after the surgery, FVC is still declining, but the rate is significantly lower than the natural history, from 8% to 3.6%, at least 5% improvement. This is a very important message. Very, very new papers from Finland, from Helsinki, a very close friend of mine, Ilkka Helenius and friends, they presented in the EPOS meeting and just a month ago in Krakow. This is the study based on Finnish registry. They looked at the mortality in scoliosis patients with cerebral palsy with and without spinal deformity surgery. And then the final conclusion, surgery reduces mortality due to respiratory causes in children with CP scoliosis. This is 2 graphs. It's clearly shown the mortality rate between treated and untreated patients. I just mentioned this quote beginning. This was the classical and the common belief, but probably now it's time to put in the cross over the knot. If we can prevent pulmonary complications because they already prone, we can help their survival rate. We can add some years to their life. As final topics I like to cover is the cost effectiveness. You know, the cost effectiveness is very, very hot topics. It's been discussed in every corner of the world, not only disability meeting, not only spine meeting, all kind of meeting, oncology, and many other meetings. This is some basic terminology. I'm sure you are more familiar with this terminology more than me, but QALY is one of the criteria to measure, to evaluate the effect of your treatment on the, in general, countries or communities' health. And the QALY, adjusted life year, it means 1 QALY represents 1 year in perfect health, while 0 death. And how many extra months or years gain with the reasonable quality after certain treatments. Today, I'm aware that many groups are working on it for neuromuscular condition. We don't have too much evidence in the literature, but this is the paper just recently published in one of the health economics journal. They have a simulation, 15-year-old patients with neuromuscular deformity, and Cobb angle is more than 50 degrees. And the PSF, posterior spine fusion, cost $50,000 per QALY gained. And they said, they conclude the study is a paper, if posterior spinal fusion results in substantial gains in quality of life, we know, yes, we are getting, and without substantial increase in mortality is the key things to prevent the complication as much as possible. Procedure could provide important gains in quality-adjusted survival at a good value. This is very important. I'd like to make a parenthesis, open a parenthesis here. I'm very close to the end of my talk. I don't want to keep you in the room in the end of the meeting. But SMA, it's very important because now that we are living in a different era, as DMT era, we called disease-modifying treatment. SMA is the most common genetic cause, still genetic cause of infant mortality. Early death is inevitable if left untreated, but recent therapeutic advances changing the natural history of the SMA. From our side, Marek and I think we are only 2 orthopedic surgeons in the room. In the past, not SMA1, but SMA2 and 3 patients, we are facing with 4 major problems: contractures, fragility fractures because of disuse osteoporosis, hip instability, and scoliosis. After the disease-modifying treatments integrated and developed, and also help of newborn screening program, now we have 3 drugs has been approved for European and American authority, nusinersen, risdiplam, and gene therapy. This is the wonderful little lady from our groups. As you see, when she was 3 months, it's typical, she was typical floppy baby. After the multiple injection of the intrathecal nusinersen, now is in the 4 years, she is able to stand, she is able to walk with some, help of parallel bar. She is looking great. As an orthopedic surgeon, I'm pediatric orthopedic surgeon. Marek told me in the last 30 years, I spent my years for neuromuscular kids, but maybe till the last 5 years, I never seen an SMA1 in my clinic because they cannot survive till to time they're looking some orthopedic care. But in the last 2 years, 3 years, I operated 4 SMA1 spine cases, 1 hip cases, and 2 of them is already planned for the next month. Anyway, with this DMT, the disease-modifying treatment, maybe we couldn't cure the disease, but we changed their natural history significantly. Now, former SMAs can be not wrong to consider as SMA2. Former SMA2 now is in 3, and 3 is now in the 4. What has changed because of this new development? Contractures, we see less and less contractures, because the contracture is mainly resulted from the all day sitting on the wheelchair. As they can move and they can stand, they can walk, they can develop less contractures. And just complementary to this, I'm hoping to see less and less fragility fractures. We don't know exactly how the hip is affected from this development, but my feeling is will not change significantly. And as an orthopedic surgeon, we will treat more and more SMA1 patients because of hip instability, because they already having a good functional capacity. But the scoliosis is very bad news. The incidence of scoliosis development and the progression, at least in the 4 or 5 years follow-up, didn't change significantly. But we are facing some new challenge. The SMA1, I cannot prove scientifically yet, but we are hoping to finalize our study in the next month or in July. We are facing different type of curve patterns. In the past, according to our experience with the SMA2 and 3, we were seen as a big collapsing spine, including the pelvis, but the sagittal plane were not really bad. But all of SMA patients I'm following presenting with a big kyphosis. This is very new to us and also very challenging for spine surgeons. This is the 2 patients from my own series. You see, all of them is the kyphotic, and the kyphosis not in the collapsing kyphosis. Some typical thoracic kyphosis is really bad. And the good news, some of them is really benefited from conservative treatment. I'm just following this this young lady is over 2 years. Deformity is really well controlled, but unfortunately, some of them require spine surgery, and we are just trying to control their deformity with the growth-friendly system. But the question may be in your minds, I don't know how many pediatric neurologists in the room, because of the nusinersen injections, it needs the intrathecal injection of the nusinersen. The spine surgery makes our injection protocols difficult or make impossible. Good news, no worry about that, because if we perform under long instrumentation, we are giving the space, leaving the space to facilitate your injections, your entry, or in the growth-friendly instrumentation, the lumbar spine, most of the lumbar spine are already free. How about the DMD? In the DMD is coming a little bit later than the SMA, and some gene addition therapy is already being approved. It's going to be in our market, in the practice, soon. We will not see how it will affect the overall functionality of our patients. But till that day, we are treating the Duchenne muscular dystrophy patients with spinal deformity surgery, like seen here. As a conclusion, just please remember my first question. Spine deformity surgery is truly beneficial for this group of patients. As you saw, my answer, yes, it works. Work to do. We can get better quality of life. But in the past, we were saying not adding new years to life, adding life to years, but possibly, I cannot say those words with a bit loudly. Maybe, I have to be a little bit, sensitive, but possibly we can add new years to their life if we can prevent complications, especially the pulmonary ones. In the DMT era, we didn't see yet any significant change in incidence of deformity development and the risk of progression. As the more patients are surviving, and it means more patients will need our help, not only surgeons, also the whole group of healthcare providers dealing with neuromuscular conditions. We have to design, we have to develop some new strategies to help them. But my final words, with careful analysis, good counseling, and meticulous planning, and of course, meticulous execution, we can improve their quality of life, we can help our hopeless children. Thank you for your attention. Happy to answer.
Thank you so much, Professor Yazici. Then the floor is open for questions.
Because of time, no more than 1-2 questions. There is one question in the middle.
Can I ask a question?
Sure, it's okay.
Sorry.
Yep. Okay. I'm saying.
A research physiotherapist from Institute of Myology in Paris. My question is, we see a lot of these kids with SMA before and after the spinal surgery. And that means we evaluate them with a lot of rigorous outcome measures like Hammersmith, Rulm, and then they're included in interventional studies. They're all on the new treatments, and then we test them also for some new upcoming treatments. But the common ground for all of them coming out of the spinal surgery, there are two things. 6 months after the spinal surgery, the pain is still an issue. That's the earliest they can be included into the interventional. And their question to me often is, when will my pain decrease? And with this, the fear of movement comes. I see them quite different than they were before. They are afraid of moving because of the pain. And the second thing is that they didn't have a lot of function, but they did have certain amount like rolling, so prone to supine and supine to prone. They did have flopping forward in seated and then lying, which is functional to them, and then coming from supine to seated with the help of the arms. They would lift their head using the arms, which was functional for them. And they did have sitting with straight legs in front of them. And these are the things they usually lose after the spinal surgery. And their question to me is, when will I get it back? Because they're cognitively present and communicative. And then I'm lost, I don't have the answers. When will my pain go away? And when will I get these functions back? So if you, in your experience, can help me, that would be great.
Both of them are great questions. First, I'll start from the pain. The SMA, it's something different because they are already intelligent and it's easy to communicate with them. But in the cerebral palsy patients, especially having significant mental retardation, we blame ourselves. We underestimate their pains over the years. I mean, with the help of pain specialists, we have to improve our pain management protocols because, I mean, this is the problem we're already discussing. And the SMA patients, why they have more pain before the surgery? Because before the surgery, they spend only limited time on wheelchair. After the surgery, their lives change. They are spending all the days in wheelchair. That's why this is something different for them. I mean, before the surgery, most of them, because of lumbar kyphosis, they are sitting over the pelvis. After the surgery, when you are just flex the pelvis, they first time, maybe over the 5th year, 6th year, they started to sit over the ischium and also is in the posterior thigh. All the body composition and structures change. It needs some time to adapt. But with the help of pain specialists, I think this problem is easily overcome. And in my personal experience, I have some patients, but the good news, not longer than 6 months or 7 months. But the critical point, from the first day, you have to consider pain is going to be an issue. You have to take some precautions to prevent them. Second question, this is very important because of time limitation, also because of the audience, I didn't go into detail. The most important problems, lots of problems, but one of the important problems I'm facing with the low-tone neuromuscular patients, the loss of head control after the surgery. It's, at the beginning, it's not easy to understand what's going on, because my instrumentation is stopping in T2, I'm not destroying the muscles in the cervical spine. Why the patient is having a control of the head and just immediately after the surgery and they lose the head control? The reason why, because of deformity, before the surgery, one shoulder is higher than the other, and the patient keeping the head straight to help off the shoulder. After the surgery, when you restore the shoulders, they can lose the compensation mechanisms. This is the problem. But good news, almost all of them can get back more than after the 6 month or maximum year. But the problem is, as a surgeon, you have to inform family and patients beforehand. You can have some head control problem after the surgery, but don't worry. Maybe we can suggest you some, apparatus or some, devices, just adjustment on the wheelchair. You can get back. Regarding the function, you are right. In the spine surgery, I show some cases getting this deformity completely corrected. We are not aiming in all cases, but sometimes we are able to do. This looks great, but at the end of the day, we are doing a surgery with a great morbidity because our surgery sacrificed the motion, spinal motion. But at least today, we don't know better than this one if they already developed advanced deformity. I'm not suggesting, I'm not the missioner standing here to suggest spine surgery for all spine deformities. No, if the deformity is not preventing their functional activity, if not being a threat for pulmonary function or eating and breathing and the hygiene, don't do anything. But if you have any two options, one, collapsing spine, making their life, terrible, and the option two is to straighten up some risk of some functional loss, I think in those stages, the spine surgery is being preferable, but I'm not suggesting 30 degrees, good functioning spine cases. Hopefully, I answered your questions.
Thank you very much. I'm sorry, we have to stop the discussion because of the time. So please move the discussion to the break. Thank you, Muharrem, for sharing and for